Okay, at this point, we're going to move on to introduce our panelists, and then we have some prepared questions for them, and then again, we'll have some more time for questions and answer after that portion. So if you do have questions, take a minute and jot them down or commit them to memory so that when we do get to that spot, we can hear from you. So I have written these down. I just met these wonderful folks this morning, and so I'm not going to pretend that I know who they are that well, but they are lovely folks. Sheriff Stacey Kincaid is the sheriff of Fairfax County, Virginia. In that role, she serves the 1.1 million residents in Fairfax County, the city of Fairfax, and the towns of Herndon and Vienna. Sheriff Kincaid received her bachelor's degree in political science and criminal justice from Frostburg State University, and it was actually her college internship at the sheriff's office that sparked her interest in a career as a deputy sheriff. This started a 30-year career at the sheriff's office. During that time, she has earned numerous professional accolades. She received the agency's highest honor, the Distinguished Service Award, which recognizes a career of sustained, exemplary performance. Lawyers Weekly presented her with an Influential Women of Virginia Award. And she is a graduate of the Leadership Fairfax, a 10-month program focused on community issues and designed to build a diverse pool of skilled, enthusiastic leaders in the public and private sectors. I don't want to steal her content, but I do want to share two initiatives of specific relevance. In the Adult Detention Center, she has expanded education and life skills program to help inmates better themselves while incarcerated and increase their chances of becoming productive members of the community upon release. She also helped to spearhead Diversion First, a collaborative county program that offers alternatives to incarceration for people with mental illness or developmental disabilities that come into contact with the criminal justice system for low-level offenses. Finally, within the sheriff's office, she has created a culture of engagement. She and her staff meet with people in their neighborhoods, in their clubs, schools, businesses, and places of worship. Next, we have Dr. Reverend Jackson H. Day. He serves as a consultant in healthcare advocacy with the United Methodist General Board of Church and Society right here in Washington, D.C. He is also a pastor of Providence United Methodist Church in Towson, Maryland. His bifocal career has included both ministry roles as pastors of churches and as an Army chaplain in Vietnam, and public health roles in project development and management with consulting firms in Columbia, Maryland. His favorite research project was a cost-benefit analysis of the family planning program of a steel company in India. Reverend Day's most recent health role was as Chief Administrative Officer of a consortium of community health centers in Maryland. He also serves as chair of the Board of Pensions and Health Benefits for the Baltimore-Washington Conference of the United Methodist Church, which provides coverage for 1,000 clergy and dependents. He was awarded the Doctor of Ministry degree in the track Faith and Health of Communities from Wesley Theological Seminary here in Washington, and a Master of Public Health and Health Policy and Administration from the University of North Carolina, Chapel Hill. He is the lead co-author of Risking Connection in Faith Communities, a training curriculum for faith leaders supporting trauma survivors. Next to him, we have Dr. William Spriggs, who is the former chair of the Department of Economics at Howard University and serves as the chief economist of the AFL-CIO. In his role with the AFL-CIO, he chairs the Economic Policy Working Group for the Trade Union Advisory Committee to the Organization for Economic Cooperation and Development and serves on the board of the National Bureau of Economic Research. His professional accolades include receiving the 2016 National Academy of Social Insurance's Robert M. Ball Award for Outstanding Achievements in Social Insurance and the 2014 NAACP Benjamin L. Hooks Keeper of the Flame Award. From 2009 to 2012, he served as the Assistant Secretary for the Office of Policy at the United States Department of Labor, having been appointed by President Barack Obama and confirmed by the U.S. Senate. I tried to come up with a summary of the many very impressive leadership service experiences, and it's just not possible, so I'll jump right to some of his equally impressive professional positions. These include leading economic policy development and research as a senior fellow and economist at the Economic Policy Institute, as an executive director for the Institute for Opportunity and Equality of the National Urban League, as a senior advisor for the Office of Government Contracting and Minority Business Development for the U.S. Small Business Administration, as a senior advisor for the Economist and for the Economics and Statistics Administration of the U.S. Department of Commerce, as an economist for the Democratic staff of the Joint Economic Committee of Congress, and as staff director for the Independent Federal National Commission for Employment Policy. He is a former president of the National Economics Association, the Organization of America's Professional Black Economists, and he is a member of the National Academy of Social Insurance and the National Academy of Public Administration. Thank you. The list actually kept going, so that was the abridged version. And finally, Dr. Marylynn Ostrowski, the Executive Director of the Aetna Foundation. She oversees the Healthiest Cities and Counties Challenge, which is focused on moving the needle on the social determinants of health through cross-sectoral partnerships in 50 cities and counties across the country. Lynn also oversees the Cultivating Healthy Communities competitive grant program, currently the only competitive grant program in the foundation, and the national grant program focused on achieving health equity through innovation. She is responsible for the Aetna enterprise-wide corporate social responsibility strategy and reporting in accordance with the Global Reporting Initiative. Dr. Ostrowski holds a PhD in health psychology, is a master trainer for Stanford University's Chronic Disease Self-Management Program, and has earned certificates of advanced study in corporate social responsibility from Johns Hopkins University and corporate social responsibility leadership from the Harvard Business School. She is passionate about the organization's mission to build a healthier world, and the work she does through the Aetna Foundation contributes to this mission one community at a time. Thank you all very much. And so we will start this panel discussion with our first question. And this is for all of our participants that we haven't heard from already. So please describe your work briefly and how it improves the health of your community. We'll take about 10 minutes to go through this one. So whoever would like to go first there.
I'll go first. I want to thank APHA and Susan and all the other staff for inviting me here today to share with you all how Fairfax County is changing the way our criminal justice and behavioral health system interact. As we know, one in five Americans have some form of mental health issue, and that number is greater inside of the Fairfax County Adult Detention Center. Too many people are brought to jail because of committing low-level crimes. And as we all know, mental illness is not a crime. So in January 1st of 2016, we launched Diversion First. Is anyone familiar with Diversion First? Okay. So if you're not, you will be by the time I finish this. So So Diversion First offers assessment as well as treatment rather than incarceration. So we're focused when someone comes into contact with the criminal justice system, our attempt is to divert them before they come in deeper into the system. In the first year of this program, we were able to see a lot of successful outcomes, although we still have a lot of work to do. We had approximately 2,000 law enforcement encounters with citizens within our county dealing with mental illness. 2,000 of those folks were able to be diverted and did not end up coming to jail, which is pretty significant. Out of the rest of the contacts with law enforcement in the first year, 375 were brought to the Merrifield Crisis Response Center, which is our assessment site for folks who have either a mental illness and or co-occurring substance use disorder. You can come in voluntarily into the crisis center, or you can be brought in by a member of law enforcement. So if someone commits a low-level crime, and when I say low level, I'm focused on either trespassing, a nuisance crime, disorderly conduct. I'll give an example real quick. A woman was arrested and brought to jail for sitting on watermelons at Wegmans. Okay, yeah, I'm pretty sure that that's not a crime, but again, it was something that what's the best way to get her out of Wegmans to bring her to jail. And that's just, for me and for my agency, that's just not acceptable. So we're in the business of ensuring that folks that are in need of treatment are hopefully, and not hopefully, that will be diverted into such. Let me see. Another major factor of our Diversion First program is training. Since the inception to this program, the county has adopted the crisis intervention team training based on the Memphis model. So far, since January 1st of 2016, we have close to 300 deputy sheriffs as well as police officers that have been certified. We also have a program that's called Mental Health First Aid, which is an 8-hour program for all staff, regardless of whether you're a civilian member or a sworn member. And this 8-hour class gives the basics on how to assess or at least recognize certain signs that someone may be experiencing some type of mental illness. Addition to that, and you've heard it quite a bit about leveraging existing resources across all sectors. Our Diversion First program is based on the the sequential intercept model. So through our partnerships with not only other law enforcement agencies, but also with the Public Defender's Office, the Commonwealth Attorney's Office, advocates, behavioral health folks, private partnerships, nonprofits, other county social service agencies, or even the schools. By us all coming together and working together, this is all part of our program and how our program is going to be extremely successful. So, thank you.
I'll be glad to go next. Very good, thank you. I'll be glad to go next, and thanks for the opportunity of being here. My work is really twofold, and it illustrates really both the strength and the weakness of the intersection of faith and health. As a consultant on healthcare advocacy issues for our denomination's social justice agency, I'm really immersed in current healthcare policy issues and strategies for promoting them. The agency is the United Methodist General Board of Church and Society, and it really focuses on the social teachings of the church. We've had social principles since 1908, and every 4 years at our general conference we pass resolutions on a number of topics which then get put into a book like this. The benefit of this is not simply having them written down, but having them used as an opportunity for education in our churches, and we promote the use of that. We have an official position which favors single-payer Medicare for all, and we favor incremental steps like the Affordable Care Act, which moves us in that direction. We are located in Washington so that we can talk with legislators, and we hope to influence legislation, and we are also devoting increasing energy to community organizing efforts at a state and local level. As a large denomination, the United Methodist Church has other agencies scattered around the country. Our General Board of Global Ministries in Atlanta includes a focus on world health, sponsors a number of health institutions, including hospitals and schools of nursing in developing countries. It also sponsors domestic health and welfare work and promotes activities in churches such as on-site recreational and health activities, classes in healthy eating, and active living here in the States. WestPath, our denominational general agency for clergy benefits, is acutely aware that clergy lifestyle impacts the cost of providing health insurance, and promotes a number of wellness programs for clergy comparable to the wellness programs of other insurers. But I'm also pastor of a small church congregation, and in that role I experience a laity that prefers to distinguish between spiritual health and physical health, with the former being the focus of pastors and the latter really seen as the focus of health professionals and not the pastor of the congregation. I asked a few members if they could tell me any message that they have heard in church that has promoted health or made them want to do healthier things, or how their participation in church and church activities has made them healthier. And several talked about how the church had helped their emotional and spiritual health, especially in times of crisis. Some spoke of the church's social gatherings as good for health. One detailed spiritual health as involving guidance, responsibility, and a variety of other things. And then that person went on to refer to the many church meals as the best medicine we could possibly need, spiritually and emotionally and relationally, but referred to the specific food at the meals as a heart attack on a plate. So that's kind of the overview of what I'll do, and I'll pass it on.
Well, at the AFL-CIO, we're concentrating on what Nick talked about in terms of policies that aim at lifestyle. So we spent a great deal of time, I think well spent time, trying to make sure that we didn't irresponsibly repeal the Affordable Care Act and leave people in a quagmire as to how they were going to access health insurance. One of the major accomplishments was to get so many additional Americans covered by health insurance, and going backwards would have been a catastrophe. We had another incident where we lost. So unions, of course, are very concerned about the safety of workers at the workplace. It is still the case that, unfortunately, one of the ways in which America is not healthy is that our workplaces are the least safe of any of the industrialized nations. And that's shameful. Last week, the Senate sent to President Trump a bill to repeal a rule that required companies to keep track of the safety in the workplace. The purpose of that regulation was to ensure that companies were always thinking, well, how could we do this better? And as everyone knows, you can't manage what you don't measure. So the idea that companies aren't keeping records means they aren't measuring it, and now you know why we have the least safe workplaces among industrialized nations. Hopefully, we'll prevail on greater logic somewhere, and we'll return so that we can at least keep track, have employers keep track, have employers monitor the safety of their workplaces. We continually fight so that we can have legislation for paid sick leave, paid sick and family days. Many Americans, unfortunately, because they have paid days, assume everyone has them. Of course, our union members have them because we fight hard for that. But we represent all workers, not just union workers. And we can't get to a healthy nation if parents can't take their child to the doctor. That's not covered by the Family Medical Leave Act, by the way. That's for someone who has a chronic condition. It's not for, I need to take my child to the hospital. That's not what that covers. So the ability to do that, when we have flu epidemics, the ability for parents to stay home with the sick child as opposed to telling the child, I'm sorry, you have to go to school sick. These are things which you would think would be common sense. Having someone who serves you food stay home if they're sick, you think would be common sense. But unfortunately, common sense doesn't prevail. In the city here, the district, when they passed their paid sick leave, they wanted to exempt food service workers. And that's the way things often go. So we fight on that scale as well. And then security. Nick mentioned security, and we have seen this in the data. This downturn stressed a lot of our communities. And we have seen that among white working class workers, instead of life expectancy going up, it's going down. The stress in the United States of what happens if you lose your job is much higher than in any other OECD, any other industrialized country. And when you think about it, it's not that we don't have good hospitals. the life expectancy for Americans who are insured is shorter than the life expectancy of insured workers in other nations. And this stress of what happens if I lose my job, about income security, about job security, about declining wages, this has a real toll. It has a health cost. It is one of the key reasons why the United States is not a healthy nation. Spending it after we get sick is not the best place to spend it. Spending it before we get sick is the best place to spend it.
Thank you. So I'm Dr. Lynn Ostrowski, and I'm with the Aetna Foundation. And I think we've heard a lot of the issues we face. There is no shortage of health issues that we face in this country. They're not getting better. We spend more and more money on them. They still don't get better. In fact, many of them are worsening. The more expensive it becomes, the health status seems to be decreasing. It's kind of counterintuitive, actually. So at the Aetna Foundation, I feel extremely lucky to be able to be very solution focused. And so what we do at the foundation is look at various areas of the social determinants of health. And while that is not new to anybody who's in public health, it is very new to the other sectors, including insurance sector. So we have all of our programs, and Nick mentioned one, the Healthiest Cities and Counties Challenge, and I'll go into that a little bit more, focused on 5 very broad categories of the social determinants of health. So we have healthy behaviors, which is the one that tends to get the most attention, right? Exercise, nutrition, those are the things that we tend to, your access to health care, et cetera. However, access to health care only accounts for 10% of the overall picture of a person's health status. And yet we spend trillions of dollars on what we can only improve in 10% of. So when we look at other sectors that actually account, your genetics, as we said, zip code is more predictive of your overall health status than your genetic code. That still only accounts for 30%. So now we've still got 60%. We've got 60% that is really very prevention focused and solution focused, but there's no dollars there. So as a foundation, that's really where our focus is. So we're looking at the built environment, we're looking at economic and social factors, we're looking at environmental exposures and community safety. And in our programs, they're very, very broad strategies. And there's a lot of things that fit underneath those domains, and that is very purposeful. The other thing that we do as a foundation that I think is a little bit different than what you see in foundations is that we are very non-prescriptive in nature. And anyone who's a part of the Healthiest Cities and Counties Challenge or our Cultivating Healthy Communities program can tell you that. So if you have a great idea and it's in a community safety, for instance. We funded one last year that I really like, and it's called a walking school bus, and it happens to be in an unsafe community. And again, this is not new, but the outcomes of this were incredible, and I'll share it with you. So in 1 year, they established this walking school bus in an unsafe community. And the teachers and the principal got involved, store owners got involved, and some key neighborhood partners got involved. And so they picked up these children from their homes, and they created this walking school bus and brought the kids to school, all obviously within walking distance of the school. Before that, there were approximately 3/4 of the population in the school at the elementary school each day. And that was not a steady group, right? So we have kids missing school consistently. One of the other issues we found in this community is that there's a high rate of asthma in this community. And so if mom needs to stay home with one child who has asthma, no one's going to school. It's not happening. And so the walking school bus actually enabled kids to get to school, and we saw the attendance increase. And obviously when kids are there, and attendance increases, what happens? We see them achieve. right? And so then and education is such a great equalizer, right? But you have to have access to quality education. And so once we get them there, they can achieve. And so that's just an example of a unique kind of program, which was actually fairly low cost in nature and highly sustainable. So we do look at these projects. The key also with our projects is there has to be a cross-functional team, a cross-sectoral partnership within each of our grants. And that is actually a cornerstone of the Healthiest Cities and Counties Challenge, is the cross-sectoral partnership. And it's a number of reasons. First, it gets a community to focus in on a priority issue, a common issue. The second piece is when the community is focused on a common issue, then the resources follow. Right? It becomes a priority across a number of sectors, and the resources follow. So now when we have that, it raises the visibility of the issue, and it brings it more attention, which then raises the chance for success. When we have folks working on an issue from, depending on what it is, you've got the superintendent of schools at the table, you have the health center at the table, you have the city planning council at the table, you have juvenile justice system at the table, you have all these people, right, representing different sectors at the table. The chances for success are going to be much higher. And then the other piece is also sustainability is higher. And from a foundation's perspective, while we put in the grant funding, one of the big things that foundations are looking for is that when the funding leaves, that the project is sustainable, or should it be funded in the first place? So we're really keen in looking on sustainability. And the other key piece, and I think Nick mentioned it when he was talking about Live Well San Diego, is the community voice at the table. We are very, very focused that in every cross-sectoral collaboration, there is a strong community voice at the table. A lot of times, some of the early mistakes we made in health and wellness was we knew what was best for the community, and so we brought these programs and put them on the communities. And even though they probably would have been a health improvement, they really weren't bought in. The community was not a piece of it. So the community voice needs to be a part of the discussion throughout into the part of the solution and actively engaged in the entire process, which actually ends up empowering the community because they feel they are a piece of it and that they are bringing something to their own community. So that's another huge piece of the work that we're doing. And then our goal is the Healthiest Cities and Counties Challenge and our Cultivating Healthy Communities programs are really what we call proof of concept. So we're looking to identify those best practices that we can then scale and spread and accelerate adoption across the country. So again, that's another focus of what the foundation's work is. So thank you.
Thank you, Lynn, and the rest of you as well. The next question we have, actually, we may end up starting at your end of the table because I think you've set the table for this one very nicely. Achieving the Healthiest Nation 2030 means making a concerted effort to tackle the many social determinants of health and moving upstream to focus on prevention. What are your thoughts on how we might prioritize the process, not the outcome, how we might prioritize a starting place given the diversity of social determinants? I don't mean to put you on the spot, but
Okay.
you set it up, so if you want to pick it up, that's great.
Yeah, I'm not sure how we really tackle the prioritizing the social determinants of health because each individual here told a very compelling story. You can't have health if you don't have a home. Right? You can't have health if you're in a jail cell and you suffer from mental health issues. You can't have health if it's not holistic. You can't have health if you don't have access to a living wage. We can't have health if we don't have access to education. So I think it's really difficult to try to figure out which is most important. And some would argue, fetal maternal health is most important, right? So if we focus on that, then, but in order to have a healthy mom, you still need home, access to affordable fruits and vegetables, quality housing, living wage, right? So it's almost like what came first, the chicken or the egg kind of discussion. So that's why we've really looked at focusing in on where communities have the energy to focus. Just like individual health, my training as a health psychologist is more individual health. And I could work with, and this is some of the Stanford training of this, working with people with self-management of chronic health conditions, is you may have diabetes, you may be a smoker, you might be overweight, and guess what? Your house is really cluttered. Okay, that could be, this is actually one of my clients' house is really cluttered. She actually had zero interest in working on medication management, learning how to communicate with her doctor, exercising, nutrition, all the things we say, quit smoking, there's a big one. But what she was willing to do was start on decluttering her house, right? It's almost like, how do we build the self-efficacy of communities to be able to believe in the change that they can make and then sustain? And so I think it's really they'll get there, but we have to go with where the energy is first and where the collective whole can say, this is an issue that we have resources right now and we have energy to tackle.
Nick, do you have some?
I just want to add to something Lynn just talked about, the community voice. And I was thinking about this question, Tom, about where's a starting place? And I think houses of worship and in one's home are excellent places, what we found. And it's the issue about the temptation of, well, let's bring in some wonderful leaders from national and local organizations and come together and have a kumbaya moment. It is being respectful of where the community is at and asking for permission from the community and giving data that's understandable, not demeaning, but understandable, and asking the community, what do you see the priorities? When I went to one community, I remember this is a long time ago, and it was in a rural community in a more mountainous area of San Diego, and it was held at a school. The whole hour was about roadkill and the animals, and that was their priority. And I wasn't with animal control, but that was important to them. I quickly called animal control folks, but my point is, you've got to go where the community's at and hear where are the needs. It's because that's how a lot of this is about trust, right? And we're dealing with a lot of fractured trust right now as a country. But locally, I think the trust is there. And if you go with good intent and you're sharing the data and you're really asking, this is the issue about the Healthy Cities and Counties movement, the community will tell you if you're prepared to listen. They will tell you. And then the question becomes, how do you start from where they're at and bring the leaders? But I think houses of worship are also great places. I don't know if you agree with that or not, or your conversations you're having with the congregations.
I certainly would agree with that. And in thinking about this ahead of time, I had looked at a list of the social determinants of health, and this particular list, I was thinking, well, we need to have faith, and we need to have faith communities on that list. Because that itself becomes a social determinant. Faith deals with purpose and meaning in life, as well as social support. Faith communities need to do more in developing their own theologies of health, also as a way of supporting health, and then help people to understand how their physical health is related to their spiritual health. Another thing that seemed to flow from that is the word agency. Having agency means believing that I can make a difference. And most people in this room are high agency people. If we decide to do something, we pretty much are able to make it happen. But I think people in poor circumstances can grow up with very little sense of agency. And having a secure relationship with God can promote agency. The feeling that God is commanding you to make a positive difference in the world can also promote agency. And if you look at the list of social determinants of health, they're all really kind of lists of things that can happen to one. And somehow my sense in looking at that list was we needed to find some way of of really empowering the individual to help make things happen. And I think that ties in with what you were saying with different words, and also what you were saying in terms of finding where the community energy is.
Well, I think the recent debate about healthcare reform shows, for me, the crux. We don't have agreement in this nation that health is a right. If we start with it as a right, then I think it's easier to make the case for these other things. It's easier to say this is what we expect our government to do because it's a right. And I think it gives people more agency because they feel quite confident in asserting a right. They'll argue with police over a right. But they are taken out of it when we convince people that it's something that you buy, and we take people's agency away when it becomes a point the finger. Because if it's not a right and it's your responsibility, and so you didn't have housing, you weren't responsible. You didn't buy health insurance, you weren't responsible. It allows us to not focus on all the things that we need to have a healthy place, including we get into arguments about, do you have the right to be safe at work? This is an economic debate. You being safe at work has to do with how much is this going to cost my company. And if it's going to cost my company too much money for you to be safe at work, then I'll make this somewhere else where I don't have to worry about whether somebody is safe at work. So I think we have to agree first as a nation on that principle, and then I think the conversations will flow from a logic once we can come to an agreement on that.
Okay, so from a mental health perspective, in terms of priorities, I believe it's going to take political gumption for lawmakers and executives to change the way we as a society deal with mental illness. We're going to need social and economic policies that recognize that mental health is in fact an illness, just like if we were discussing heart disease or cancer. We need cities, counties, and states to not only acknowledge the need for more psychiatric beds, but also to fund them. Just as important, we need localities to provide long-term supportive housing so people in need have a place to go, a place to call home. Until there are enough places for us to divert people with either mental illness or a developmental disability, people will still be brought to jail, they'll still be kept in jail unnecessarily. And as I like to say, you wouldn't take your car to a dentist to get fixed. Why would you bring someone who has a mental illness to jail to get treated?
Thank you very much. Okay, let's move on to our next question for the panel. Cross-sector partnerships are critical to achieving the Healthiest Nation 2030. Can you highlight examples of ways, and for the sake of time, let me maybe just pick one. Highlight an example of a way in which you and your own organization have worked with different sectors to achieve better health outcomes for the populations that you serve. And in doing so, can you point to any particular health and all policy efforts that were particularly impactful? I'll leave it up to you to see who's going to go first on that one.
I can jump in there. So we don't work directly with populations. We're really on a funder, so there's a little bit of an arm's length. But I'll just give you an example of a powerful cross-sectoral partnership. And I'll use the one I talked to you about, Healthiest Cities and Counties Challenge, and recognizing that no one sector can do it alone. We as a foundation recognize that ourselves. And when we were discussing this idea, we immediately reached out to the American Public Health Association. They became an anchor partner with us to have that strong public health focus. It was very important to us that this was a public health focused program. We also reached out to the National Association of Counties because we wanted to make sure that counties were included as well as cities. And as the program has progressed, we have brought additional partners to the table. We brought the National Partnership for Women and Families to the table, and their role is to help our communities that are participating in the challenge to engage that community voice, to make sure that that is part of the cross-sectoral challenge, or cross-sectoral partnership, that it's there, that it's strong, that it's going to remain there and be part of the project throughout the life cycle of the project. We also brought Brand in to evaluate the overall process, understanding that they have something that they can bring to the table that they're better at. So we're really looking at bringing in various experts. But I think the real bottom line of the whole thing is, regardless of what your title is, regardless of what industry you work in public health. Every single one of us wears a public health hat. So if you work in and you're a city planner, guess what? When you're figuring out where the sidewalks are and where the street lights are and where the, crossing lanes are and, you're working in public health. If you're an educator, you're definitely working in public health, right? So we all work in public health regardless of our titles or our industry. And so I think it's a recognition of that, and maybe that gives advocacy to individuals. But in order to give individuals advocacy, you have to give them access.
Just to add on to my friend was, again, it's about the relationships, it's about the stakeholders, and the reason why Diversion First has become successful, even though we still have a long way to go, is because of the partnerships that we have, the stakeholder group. We have over 180 stakeholders. And to bring everyone to the table, everyone has a seat at the table, everyone has a voice, and it's not just the attorneys, it's not just the behavioral health folks, it's the advocates, it's also the consumers. And listening to the consumers is extremely important, and also giving them a voice, whether it's public health, whether it's mental health, whatever you want to call it, in order to have a healthy society. It's important to have the commitment and have the will to move forward with everyone.
Let me just mention one project that we're very delighted about. We gave a little bit of funding to this from the national agency, but it's called the John Wesley Health Center. It's in Durant, Mississippi, and it was formed when a pastor was assigned to a very poor area with a church that by all respects could be considered on its last legs, maybe a dozen or so dispirited members. And she was able to establish what was called a health education center. Nothing elaborate. It was open Tuesdays and Thursdays. Those attending enjoyed a prayer, a brief Bible study, a nutrition discussion, snacks, exercise, a game centered on enhancing brain activity, Alzheimer's prevention, and so forth. And the result of this, though, was that it energized the community. It was something that the community realized that this was something that they were doing on their own. It was based on volunteer activity. As a matter of fact, later on, once it had been successful and replicated several places, there were some funders that wanted to throw actually a lot of money at this, and they rejected it because they said, no, the secret of this is that it is developed from the community up, and we don't want the money, which would essentially change the whole purpose and focus of the program. So we're very pleased at how that had turned out.
So at our affiliate level and at our state Fed level and at our Central Labor Council level, there are lots of partnerships because many of members of organized labor are healthcare providers, whether they're members of the American Federation of Teachers and Service Nurses, or whether they're firefighters in the public sector, but it's at that community level where you have the ability to have legitimate voice, and having workers organize gives them a chance to exercise that voice and exercise that leadership. So I think you'll see lots of partnerships when you go to that level, to see people on the ground, whether it's organizing local marathons or healthy runs, or being sponsors for the kind of things that their communities need dollars and people to make it happen.
I think there's another type of partnership we can't forget, and that's the cross-generational partnership. So I want to give a shout out to the grandparents in the room. San Diego, we have a big issue around grandparents raising grandkids. It's not just in San Diego, right? 50,000 foster kids in California, hundreds of thousands across the country. But it's not just foster care. It's just how, as a society, because of the strains we have on working families, the importance that our elders have. So another nice phrase, intergenerational, there's a lot of intergenerational. I would argue to say that is as strong, if not stronger, than the cross-sector organizational collaboration we're talking about, is how do we support that cross-generational relationships? And that is something we should step up as our call to action this week and beyond, because that is, I think there's one abundance of a natural resource. Oh, that's right, the baby boomers. We got people that need purpose and have passion. How do we align them with kids, with people that are socially isolated in homes, having really a relationship and a partnership with people leaving the justice system, right? So that correctional care coordination, sometimes not having that type of person that can guide them. So I think I don't want to miss the importance of the generational kind of partnerships that matter as much as the organizational agency components we're talking.
Thank you, and again, that's a very good segue to our next question. What other cross-sectoral partners should we be bringing in, should be included in this conversation?
Well, let me jump in first on that. I think you mentioned in my background that I was once an Army chaplain, and I would suggest that we need to bring the military in. The experience when I was a chaplain within the military environment was one of working with other people with the well-being of the entire group of people in mind in a way that I don't experience in the civilian sector. And so I think that the military has a lot to offer just in that way.
Well, I think it would be good to bring in journalists. We really need people to focus on what is happening to Americans, and they need to follow a mom who is a crossing guard for a school, whose job used to be a public sector job but has now been privatized, and see her struggles without paid sick days. See her struggles with the pressure of making it to the next paycheck, and understand and tell the story of what it's really like, and look at issues of workplace safety for her, responsible for making sure that the buses don't go running around, having cars go running around the buses. This is something that Fairfax County has been cracking down on, people who want to drive around the buses while we're trying to get our kids on and off safely. There is too much of a lack of making that public and getting people to talk seriously about why we aren't healthy. I think there's such a focus on our diet, and many of us have stopped smoking, and yet we haven't dealt with these these things that make the 40%, the 30% that was being talked about, that's the part to me that's been missing, and it's such a big part of everyone's life.
Yeah, I think I would add our legislative delegation, and some of our cross-sectoral partnerships do have legislative leaders and our elected leaders. But in order for this to really take hold and create this culture shift in our country, we really need health as a priority agenda, regardless of what community, what state, what county you live in. This has to be part of the agenda, because once it's part of the priority, then the resources, hopefully the collective resources, will follow so that we could achieve some impact.
I believe education, early intervention with the schools, starting out early to recognize, as you heard from Nick, which I think you're doing, you've got some great initiatives. But in terms of, and I'm speaking from the mental health aspect of it, that being able to identify and bring awareness, as well as with our human services and social services partners. That's my thought.
Thank you all very much. We do have a few questions specifically addressed to each of you. I do want to check out with the audience and see if we have anyone in the room that has a question at this point, because I don't want to ask your question if you already have one. We do have microphones on the sides of the room. Do we have any questions from our live audience? And I'm not seeing any hands going up or bodies rushing to microphones. Oh, yes, we do have a question. Nick, you want to?
Well, for us in San Diego, the trusted source have been in schools. We have expanded, though, beyond the K-12 to preschools. And so we have now preschools as Live Well partners. And was interesting for us is that it was not only the workers of preschools, but then the parents that were benefiting beyond just the preschooler. So I agree there could be an abundance and sometimes conflicting. So we've tried to create that potent simplicity of where is that trusted source. And in many cases for us, it has been the education. Now, not all parents have school-age kids. And so in that case, then we rely on who are those trusted entities. And it could be the YMCA or Boys and Girls Club. It could be faith. So it's who's in that community that works with that general neighborhood that we go to be that trusted source. So that, I think, again, it gets back to who does the community see, and then working with that source of trusted information.
I'm going to, without someone jumping onto the mic, I want to take a little bit of APHA president prerogative, I guess, if nothing else. But really, that your question underscores the necessity of being very proactive, very deliberate, and very inclusive as we pull together our multi-sectoral partners. And this is one of the roles. I'm a local health officer in a medium to small size health department in Ohio. And one of the things that we do is we make sure that we have really taken on that role of chief health strategist in our community. So as we bring those partners together, it lessens the burden of diverse messaging when we're all kind of speaking from the same page to begin with. That way, whether it's coming out of the school, the library, the Y, the Chamber of Commerce, whoever it is that's putting it out there, at least has had the opportunity to be speaking from that same playbook. And so it underscores that need to be very proactive and very deliberate on the front end. Thank you all for allowing me to jump in on that.
We do have a few questions from Twitter.
Thank you. Susan, would you take care of those for us?
Sure. So the first one was, are any of you working on mental health improvement through physical activity in the built environment?
So that is one of the areas that is covered in the Healthiest Cities and Counties Challenge, and there are 50 cities and counties, so I can't off the top of my head think of one that's tying those three together, but I invite you to go to healthiestcities.org, and the site is very robust and can give you an outline of cities and counties that are doing that work.
One of the interventions that unfortunately is woefully underfunded is what they call clubhouses. And that is for people who are challenged with a mental health condition, a severe one even, in terms of trying to get them on the path of independence as much as possible, but giving them those skills. Many of those programs are woefully underfunded. So we're looking and trying to expand those type of clubhouses. So they're primarily more of an outpatient or during the day, where they're learning just skills of how to cope with others, giving them a skill maybe even on how to get them into the workplace. And that's the notion that people, the stigma about with mental illness is that these folks, they can't really be reassimilated back, and the answer is they can. And so how do we provide those kind of rehabilitative kind of services for them and wrap around them? And so those are some of the interventions we see that are very helpful.
So inside of our adult detention center, we have a variety of programs, from everything from educational to being able to workplace skills, employment skills, employability skills. We have religious programs. We have, we're looking into right now an apprenticeship program. And what we have recently done in the past 2 years is had our first inmate resource fair. Because again, we're focused on reentry, and along with reentry, it's important that we have at least be able to provide the information, the skill set for folks, so when they go back out into the community, that they're able to be successful, they're able to live healthy lives. With these vendors that come in on our inmate resource fairs, they connect with our inmate population when they get out of jail, and they're able to work with them to have some type of sustainability in terms of housing or employment. Even with Department of Motor Vehicles, oftentimes we have folks that get locked up that don't have a driver's license, and they have no government ID, so when they get out of the jail and they try to go get a job or they try to get a home, rent a house, they have no ID. So our partnership with DMV Select, we're able to provide folks with a government-issued ID, so when they do get out of jail, that again is very helpful to them being able to be productive and to live healthy.
Oh, there's another question in the room.
Hi, everyone. My name is Anna Ricklin, and I'm with the American Planning Association. And today, we have a partnership, an ongoing partnership with APHA. And today, we released a call to action to promote healthy communities with a number of other national professional membership organizations and associations, including folks who represent the architects, landscape architects, the developers with the Urban Land Institute, parks and recreation professionals, a number of professionals across the built environment and public health spheres. And I'm just wondering, we're calling upon our members to build partnerships and work together on removing barriers to healthy communities. I love that Dr. Ostrowski called out planning specifically as a public health strategy and a way that we can promote healthy communities. But I'm wondering just to hear from all of you, from your perspective, how we can begin to build these partnerships. What do you think would be the first thing that you would tell a community member or a professional who's working in one of the public agencies that you work with?
I'll take a jab at that question. Last week, I had the opportunity to participate in a behavioral health criminal justice summit down in Washington, D.C. We're down in Washington, D.C. We're down in Washington, D.C. now. I'm from Virginia, so down in Washington, bear with me. And the interesting thing about that is that, and as I mentioned previously about the stakeholders and the importance of having stakeholders, people from all different walks and talks of life, at this summit, there were people that I'd never worked with. Again, people that were served on boards and commissions in the District of Columbia, as well as folks that were from out of state that had different jobs, whether it was with the private sector or nonprofits. And this was information sharing and awareness and who's doing what and how can we work together to achieve, our goal. And I mentioned at the summit that, we could probably sit in this room for another, 7 days or something, and we'd probably leave here with the model of how to certainly, make things better, if not change the world. But we'll work on making things better for right now. So again, my thoughts are that the awareness piece, the ability to reach out, the commitment, and getting people on board.
Okay. We have another question from the room.
Yes. Good day. I'm Tatiana Warren from Bon Secours Baltimore Health System, specifically Community Works, which is a subsidiary nonprofit organization with the hospital. And we primarily focus on addressing the social determinants of health. I'm excited to be here. We apologize about our lateness. We had another conference with Kaiser Permanente with Lab City in Baltimore. But we could not miss being here because we represent the 21223 zip code in Baltimore City, which is a zip code that is the worst in the areas that we don't want to be in terms of social determinants of health. High rates of low literacy or educational attainment, income below poverty level, the lowest life expectancy rates that we see in comparison, just a zip code right next to us. And so one of the synergy topics that I've heard today that I really, really like is talking about having the community actively involved in what's important, right? And so there's a process that we do, it's the Community Health Needs Assessment every 3 years. And we just finished our second round of the CHNA plan and assessment. And, we would think that it would be crime. We deal with a lot of that in the West Baltimore area, shootouts, 9 o'clock in the morning, and everyone's working like normal. And forgive me because I'm new to the area from South Carolina, so I'm not used to that. And so what we hear the community say is that no, crime is not an issue, or crime is an issue, but it's not at the priority. It's not the top of our priority level. Drug use and mental illness and trauma is an issue, but it's still not at the top. It's trash and rats, right? And housing, tons of vacant properties. And so the hospital, as well as Community Works, has listened to the community and made sure that that's at the forefront. So I applaud you for honing in on making sure that the community's voice is active and that we're listening to the community members. And then the other thing that I wanted to talk about is many of our clients, patients, participants, what have you, come in an in-crisis state, right? So they're getting ready to be evicted out of their house. So our financial services department, along with, of course, partnerships, provide eviction prevention services. Or they're without a job, and we have occupational skills training programs, CNA, GNA, which is a big push right now. Cleaning green, so cleaning up the community. There's no grocery store. And getting to the closest grocery store is like 3 miles out. And so there's not adequate transportation to travel with your eggs and your milk on a bus. And so, we've built a hoop house. And so we have a community garden and just doing things that the community, really, truly the things that we the programs and the services that we roll out to the community is directly coming from what the community has asked for, they want. And now, you know, a youth development center. We have a library in the community that has been closed for 20 plus years, Enoch Pratt Free Library. So our students, and we service 6 public schools within the footprint of the hospital, but there's not a library. And we're closing schools down and we're merging schools. And so I just love this idea of, you know, focusing on what does it really look like to become a healthy nation, but more importantly, what does that look like in terms of healthy counties and healthy cities, but even specifically within a zip code, right? And the hospital uses a place-based strategy. So we're unlike the Johns Hopkins that has a campus on the east side and the west side and northwest, or even University of Maryland. We have a 5 zip code radius that surrounds the hospital, and we're active at all of their community associations. We have crime and grime meetings. You know, we attend the sessions with the community members. And so, and it takes a lot of effort. But I think one thing from the staff and from the community members is that we're so focused on the mission, which the Sisters of Bon Secours, which is it's a faith-based hospital, Catholic, came here 100 years ago, you know, knocking on doors to provide health, and really doing the leg work from a grassroots effort, and we've continued to do that regardless of what funding opportunity, you know, not chasing the funding opportunities, but really listening to what the community is saying, and then looking for partners to help with that mission. And so I guess I didn't ask a question and I was long-winded.
That's all right. Thank you. Your stories have really sort of underscored and validated a lot of this conversation. I thank you for taking the time to sharing that with us.
Thanks.
And could I add something to that?
Sure, certainly.
And just listening to you was very very impressive, and I live on the edge of Baltimore myself, so it's close to home there. But you had mentioned earlier on in the conversation conducting a health needs assessment, and I was listening, and implicit in a lot of the things that you have done there in working with the community and in developing the community's capabilities. You really have either formally or informally done a community health assets assessment. And I just wanted to lift up that particular phrase, because if all you have is needs, that's often quite disempowering. But when you look at the assets, that's when you begin to see what some of the potentials are for addressing the needs. I just wanted to highlight that.
That's a very good observation. Thank you. And Susan, was there another question from the out there, wherever you call Twitter?
There was, and Nick, this one is directed to you. The question was, in terms of your San Diego Live Well project, how active a participant is the Navy, and are there ways that you would like to engage the military and the Navy more directly?
Well, I think it was mentioned, the involvement of the military. For us in San Diego, we have a large population of active duty families and veterans. In fact, 1/3 of our 3.3 million residents are active duty family members of, and veterans and family members of. So the Office of Military and Veteran Affairs actually reports to me. We moved that, interestingly, that office that has been sometimes associated, kind of its own standalone. We said, no, this is about helping and providing wellness for those that are caring for our nation. In fact, our belief is we got their backs because they got our backs as they're defending our nation. And so with that mindset, we've done things that are unprecedented. Like, we actually funded and developed a child development center on active military bases because there was such a need of military children, and in some of these cases, the movement of children and families, for those that have had parents or were military child know. And so I would say beyond the sharing of the data, we actually are working with the VA, the military, and sharing electronic medical data. We have all of our hospitals and clinics that are sharing patient medical record with patient consent. But it goes beyond that. It's what are we doing for those families? So I would say it's a very active participation. And if you want to meet some of the most humble group of people, it's going to our San Diego Veterans Coalition. We have about 140 different veteran service organizations that meet monthly. And all they're there is to talk about how they're to help veterans, other veterans and families. So they are all part of the whole Live Well movement. We measure that as a key piece of how we're helping our active duty and military and veteran families living well.
And we have another question from the room.
Hi, my name is Jillian West. I'm at the Urban Institute. We actually administer a program of the Robert Wood Johnson Foundation called Policies for Action. And so we're looking at sort of thinking about all these social determinants of health, of transportation and education and housing, how the policies and laws that are actually in place at a national level versus state level versus local level are actually sort of really leading to tangible, measurable health outcomes for people. And so I'm just sort of wondering from this cross-sector sort of lens, you know, you have to get buy-in from lots of different people to sort of get policy change in place. And I'm just wondering about your sort of experiences working with either local policymakers, elected officials, sort of others in that space, and how much how important it is to be cross-sectoral in that sort of ask and getting that kind of buy-in.
Yeah, so I think the big challenge is that on the federal level, these are different pots of money. So if you want to solve the problem of access to health care through transportation, that's transportation. And if you want to address problems of homelessness, if they're veterans, then it's the Department of Veterans Affairs and the Department of Labor. If it's homelessness, it's HUD. It can be difficult at the local level for local government because solving these means you need all the money to come together at the same time because you're running a unified program. So part of it is just getting the federal government to cooperate on how can I apply for money when, for instance, if it's for training veterans and health care, that money is July 1 and other federal money is October 1. So the money comes at a different time and I can't sync it. And then part of it is at the local level, their own silos. So getting them to understand that a decision like, you know, Metro wants to make a decision about when do you shut down service. Okay, but then how do I get to the hospital? And, you know, you get a blank look from them, but how do I get to the hospital? So it's getting people who live in their silo to step out of their silo to actually sit down with the delivery of these services. And it is a challenge, and not just the federal level, but on the local level, or thinking about issues of reverse commute for suburban hospitals where many of the lower wage occupations are going to be people who don't live anywhere near the hospital. And how do they get there in the evening, or how do they get there on off shift time? These are things which often don't come into the conversation, but have to be part of it as well. So I think those are the challenges: is to break those silos.
You know, I think it's great that you're supporting this type of leadership role. And I think Tom talked about it. It was the health strategist kind of role. But there was an article by APHA, this is decades ago, and it talked about, and it still resonates for me, it's that you're going to have really a trilogy of 3 historic roles, right? Don Quixote, right? Robin Hood, and the prince, Machiavellian. And Don Quixote, you have to have the vision.
Someone needs to retweet that.
You have to have the vision. And the vision has to come from your deeds, not just your words, because the community will see through. They will judge your deeds. Right? They may not believe your words, but they will believe your deeds and the work you're making over time. And then how you shift resources. And whether you can get resources from the federal government, good luck. But what we're talking about, cross-sector collaboration, it's innovating what we don't even know today. Other sectors are bringing in those resources. And then the skill set I'll mention for this group, because there'll be a fireside chat on the other skills, but the one I would mention for this group is empathetic listening. Empathy, listening. And if you're going to come into the space of being this kind of collaborative, cross-sector leader, you better be prepared to have that empathy and listening, because I think that's what we're missing often enough. But if you could do those three and then have just a fourth, have a Jiminy Cricket somewhere there, give you some advice along the way, I think you can go a long way.
Thank you very much. I think we have one more question from the Twitter sphere.
Yes, and building on that, what would Jiminy Cricket say we need to do to create the healthiest nation? We know that our life expectancy is dropping. We know that that we spend more money than any other country and our health outcomes are poor. So what is the first thing that Jiminy Cricket would say we need to do?
Well, I think Jiminy Cricket has a lot to say here. But I really think setting the clear vision, one of the things we don't have across sectors is a common understanding of the issues and how we affect those issues, depending on where we sit in that sector. And so there's a lot of work to be done just there, helping people understand, almost creating a line of sight, so to speak. We do it within our organizations and corporate social responsibility. We want everybody to know that every time they flip off the light switch, right, that they're helping us with our environmental sustainability and footprint. So how do we create that line of sight across all organizations that help them, agencies, organizations, private, public, whomever, to understand how they impact that and what they do. And so I think that would be Jiminy's first set of advice.
And I would go back, Jiminy has to get us all straight. It's a right. Health is a right. It means nothing to say life, liberty, and the pursuit of happiness if you don't have the right to, if life is not a right, then the rest doesn't follow. And so health must be viewed as a right, and then I think it's easier to solve the problem, because then it has to be solved. This is not like it's an option. And people don't have to fight for it, and we have to realize, as long as it's not a right, and a society where we have let inequality become toxic, so that inequality actually drives our systems, then we can't solve the problem, because inequality intersects with everything that's market driven. We have a society that's market driven, which means that price is the allocator, and as long as price is the allocator, it will ration some people out. You are rationed according to price. So if you don't have the money, then you are rationed out. And because of our growing inequality, healthcare is going to continue to spend more money, because it's the wealthy who live longer. It is the wealthy who have the money to spend on health. And so we will spend money where wealthy people want to spend the money. So if it's immunization for kids, there's no money in that. That won't happen. If you want other things to happen, then you have to have it as a right, and then you have to. Then the number one priority would be childhood immunization. The number one priority would be, why do I have to call 911 and get an ambulance in order to figure out a way to get to the hospital? Because it's not my right to be able to have public transportation to get me to the hospital. So I'm going to use the most expensive way I can figure out in order to get to the hospital. And why am I going to the hospital anyway? Why don't I have the right to see a doctor? So, I mean, as long as you're going to have a market-driven system in a world where you don't accept health as a right, then it's going to be chasing your tail for some time.
I think I'd like to add to that very much. Certainly, one of the social principles that the United Methodist Church has endorsed is that of health as a right. But you have centuries, millennia of experience of the provision of health as an act of virtue, an act of charity. And it takes a lot of rethinking to realize that if you receive health care as a right, that's about you and your benefit. If I provide you with health care as a charitable act, that's really about me and my benefit. And it's a really major shift, and we aren't there yet. But I certainly support that.
Get you off the hook on it.
No, we'll save the best for last. So, no, again, it goes back to collaboration. It goes back to having and wanting to make something better. And I know I hear about marketing and I hear about money. And, you know, at the end of the day, I truly believe it's about human capital. And maybe I just see the glass half full way too many times, but working with folks who, again, what matters to one may not matter to another, but this operation, you know, in silos, I look at that as an opportunity to bring people together and, you know, how does this affect each one of us? Because in some way, things do affect each one of us when it comes to health and when it comes to the well-being and the caring of our families, our friends, our neighbors. So that's my thought on Jiminy Cricket for today.
And I think Jenny would remind us that when we're talking about working across sectors, that it's really about visionary leadership, which is seeing what everyone else is seeing, but doing what no one else has thought, at the cost of mockery by the present for the betterment of the future. So mockery lane is a tough place to go for us. And who ordained you to be the leader of the cross sector or that? But if we know we're pure in heart of what we're trying to do, that visionary leadership will guide us, and it's really all up to us to do that.
And I'll make this sort of my final words before we pass it back to Susan to wrap us up. You know, the idea here of multi-sectoral approaches, of working with new folks in new ways and being innovative, we need to remember something that was said earlier when we go to the community, and we go to the community as experts, and we lay it on the community. We can do that same wrong approach when we bring in multi-sectoral partnerships. So what we can do is also learn from that and say, there's a right way to do this. And oftentimes when we think of collaborations, collaborations tend to be episodic, relationships tend to be enduring, and the best way to have those relationships is to go in, as my colleague said, with that empathetic listening, to understand what their agenda is, to bring their agenda on and see where it matches our agenda, to see where their language is and match it to our language. So we can still get there, but we don't have to own every piece of it. We don't have to certainly take credit for any piece of it. We need to make sure that we're learning and we're talking to each other as if we did, because that's how we talk to each other. But in order to make those enduring relationships in communities and to truly have those multi-sectoral partnerships, we need to be open to the idea that they're bringing a priority that we might not have thought of, because ultimately it's still going to benefit the public's health. With that, I'm going to wrap up and push it over to Susan.